Well, good afternoon, and thank you for joining us for today's University Hospitals Health Talk. If you're in the Cleveland area, I hope you're enjoying this lovely sunny fall weather that we're having. A couple of housekeeping notes before we begin. So in this platform, all attendees are muted. We will, while you won't be able to ask questions through the audio, we would love to have your questions. And so you can submit those through the Q&A function, which you'll see on your screen. If you have a question that's not addressed during the presentation, please submit it through the Q&A feature. And our presenter will has a dedicated Q&A section at the end of the presentation. So we will try to address as many of your questions as possible at the end. Also, today's webinar is being recorded and will be posted on our website for you to view at a future point in time if you're interested. And of course, as a registrant of today's session, you'll also receive an email with the link to that webinar. It is now my pleasure to introduce our presenter for this session. Jean Marino is a women's health nurse practitioner at University Hospitals, and she specializes in both menopause and female sexual health. She is also a North American Menopause Society certified menopause practitioner and has a fellow designation from the International Society for the Study of Women's Sexual Health. Jean developed both a menopause clinic and a menopause education support group at University Hospitals, and she's also currently a practicing member of the Female Sexual Medicine program at UH. Jean has had her work on menopause published and has provided other presentations and education on the topic. So we are very lucky to have her sharing her expertise with us this evening. Now I'll turn it over to Jean. Thank you.
Okay. Hi, everyone. I'm so happy to talk about menopause with all of you, one of my favorite things to talk about. So tonight I'm going to talk to you about what exactly menopause is, how we diagnose it, what are some of the most common bothersome symptoms, and then, of course, let's talk about some treatment options for those things. So just to kind of give you a little bit of background, I wanted to go over this reproductive timeline. So when someone is premenopausal, what that means is that she is having regular and monthly periods. This is characterized by fluctuating hormones and ovulation on a pretty regular basis. When someone is perimenopausal, that's the time leading up to menopause. And this is also characterized by fluctuating hormones, but it's much more erratic hormones. And ovulation is not occurring on a regular basis. And important to note that this can last for up to 10 years ahead of time. And then menopause or postmenopause, those two terms can be used interchangeably. That is characterized by just overall low levels of hormones. And what menopause is when you outlive your ovary's ability to produce an egg. And so therefore you're no longer ovulating. So some of those changes that come along with menopause, the big one is that when you outlive that ovary's ability to produce an egg, you're going to lose about 90% of your estrogen, which is gigantic. That decrease in ovarian feedback is causing this increase in follicle stimulating hormone, or the FSH. So that FSH is a hormone coming from your brain down to the ovary, telling the ovary, like, come on, let's go, let's produce an egg. So that's why that number can get pretty high. The SHBG stands for your sex hormone binding globulin. That decreases as your estrogen goes down. And that's important to remember because what that means is that there's not as much testosterone bound up. So you actually have an increase in available testosterone. So not high levels of testosterone, just more available testosterone. And don't think that that postmenopausal ovary is just lying there dormant. It is still secreting some hormones that can then be converted over to estrone, which is the type of estrogen that's dominant in menopause. So this is important to keep in mind. So women who have had their ovaries surgically removed, or they've been damaged by chemotherapy or pelvic radiation, they don't have this buffering, if you will. So their symptoms can be pretty severe. So one really quickly, I would like you to take a look at this slide because what I want to show to you are the fluctuating hormones. This is a woman going through perimenopause. The dashes are when she has her period. And what I want you to take note of is how up and down the follicle stimulating hormone is, the estradiol levels as she's going through perimenopause. Because my question to you is, how helpful is it to draw labs? Should we be checking that FSH, estradiol, progesterone, AMH? If you haven't heard of AMH, that is the way to measure ovarian reserve. So women ask me all the time, shouldn't we be checking hormone labs? And the question is, those labs are not helpful. So, what we should be doing is treating based off of symptoms. So, if a woman tells me that she is having terrible menopausal symptoms, I don't need a certain number to treat her. We should just be believing women, listening to women, treating women who have these symptoms. Right now, there's no lab that can predict when a woman's going to be in menopause. They've looked into that AMH level to see if that's something we could use in the future, but right now that's just being researched and nothing like that's in practice. Also, there's no lab that can tell me when you're going to be done going through perimenopause and in menopause. I hear this all the time. Don't we want to see where I am right now? And there's no lab right now that's going to tell me, oh, you only have 6 more months to go. You've got 5 more years to go. It just doesn't exist. And those hormones are all over the place. So much better to just treat based off of symptoms. So then, how do we diagnose menopause? Even in 2021, it is no more sophisticated than counting periods. So, what we're looking for is 12 months in a row with no period, or the medical term amenorrhea. And that would be what we would consider natural menopause, when you're outliving your ovaries' ability to produce an egg. When you have an induced menopause, what that means is that either the ovaries were surgically removed, or again, they were damaged with it, chemotherapy or pelvic radiation. So if someone's had a hysterectomy, or her uterus was surgically removed, obviously we can't count periods because they don't have it. Those women don't have periods. So what we would do is just treat any bothersome symptoms. Again, it doesn't matter if you're 51 and you have a hysterectomy and you have hot flashes. It doesn't matter if you're perimenopausal or menopausal. We can offer you treatment. So the average age of menopause is right around 51, but anywhere from 40 to 60 is considered normal. So the loss of estrogen, remember I was telling you, it drops by about 90%, is really significant because you have estrogen receptors everywhere. They're in your brain, they're in your hair, your skin, all throughout the pelvis, the vulva, the vagina, the urinary system, your heart, your blood vessels, your joints, your bones. And so that drop off can really affect everything. So these are the more common signs and symptoms of perimenopause and menopause. So hot flashes are the really big one. Affects a good 80% of all women. We're not even entirely certain what causes hot flashes. We know it affects that part of your brain that monitors your temperature, so kind of like that internal thermostat. They've also looked in some of the nerves that lead to that part, and they actually change in shape and size related to estrogen. Probably also serotonin plays a role, how healthy your brain is plays a role, but hot flashes really, really common. And for some women, these can be quite severe and go on for a really long time. And if you are one of those unlucky women, make sure that you are keeping a really close eye on your heart, because they do think that women who have severe prolonged hot flashes, that might be an indication that she is at risk for heart disease. Also, changes in menstrual pattern, really, really common. It happens to everybody. For some women, that means periods get lighter, shorter, start spacing out. So that's not so bad. Other times, periods can get heavy, more frequent, prolonged, and again, all related to not ovulating on a regular basis and those fluctuating hormones. Mood changes, gigantic. So, estrogen so important in the brain for all those neurotransmitters. Mood changes can be quite significant. And we know that this doesn't affect everyone, but we do know that there are some women that we would call vulnerable or sensitive to these mood changes be related to the hormones. I mean, why do only some women get PMS and only some women have postpartum depression? I mean, we're just all built a little bit differently. So I would argue, if you've had a history of PMS or you had some mood changes with either postpartum or during your pregnancy, I would actually be surprised if you didn't have some mood changes now. Also, anyone who's had a previous history of depression is at risk for a major depressive episode during perimenopause. Brain fog, difficulty concentrating. Sometimes women are concerned that means that they're developing Alzheimer's or dementia. That is not the case. Difficulty sleeping. Sometimes this is due to hot flashes, sometimes just due to those hormone levels. And if you're not sleeping well, it absolutely affects brain fog and concentration. Absolutely affects mood changes too. I mean, just pretty much everything is worse when you don't sleep well. The vulvar vaginal dryness is huge, and we're going to get into more of that towards the end of this presentation. But you could also have thinning hair on your head related to that drop off of estrogen, but then maybe more hair on your chin and your chest and acne. And those symptoms are related to that more available testosterone for your body to use. You could have dry skin. I could have added dry hair, weight gain, especially in the abdomen. Sometimes they call this the menopause middle. So when you lose that estrogen, your body puts more weight right in the abdomen. And weight gain in menopause is just, there's so many things that affect this. So if you aren't sleeping well, you might be less, apt to want to go out and exercise. So that can contribute. Also, your body starts to release some different hormones to help you gain weight or at least make it more difficult to lose weight. The mood changes could make you have weight gain. Women more so than men tend to be more emotional eaters. And so usually when people are not feeling well and they kind of reach for comfort foods, I mean, good for you if you're reaching for carrots. I know my comfort food is our milk duds. So not usually really great for weight gain. Joint pain, that can affect moods, absolutely affects weight gain if you're not as active. And then, of course, some urinary frequency, more frequent bladder infections, and those, we're going to get into more of those symptoms in a little bit. I would also like to remind all of you that, and I'm sure you've already noticed, so many social, cultural, personal changes. So when we're talking about the whole woman, we should be looking at all aspects of her. So this time period in women's lives can be challenging. Often we're called the sandwich generation. So you may have dependent children you're taking care of, but then older parents that you might need to take care of. There can be lots of changes in your job, your relationships, financial changes. And some of these could be really positive, but sometimes they're not. And then, of course, what does menopause mean to you? So, for some women, when they stop having their periods, there's a sense of freedom and they're relieved. For other women, they were told once they got their period, well, now you're a woman. So then when they stop having their period, some women kind of feel like, well, now what? And then that loss of reproduction, again, for some women, this is very freeing. And then for other women, even if they didn't want to have any more kids, even if they never wanted to have kids, sometimes this is still difficult. And then our society tends to value youth and that ability to reproduce and some very strict beauty standards. And we can choose to not internalize those things. But for some people, that is difficult. And so then this can be kind of a difficult or scary time in your life. The good news is I have lots and lots of treatment options for you for those bothersome symptoms. So, first, let's talk about hormone therapy. So, when we're talking about systemic hormone therapy, what that means is those hormones are getting to all different parts of your body. And we're talking about estrogen and progesterone. So, estrogen is the main hormone when we're talking about treating symptoms. And we can do that either as conjugated equine estrogen, and so it's in the name Premarin, pregnant mare urine, or estradiol. And then progesterone, the main reason that we give it is to protect the uterine lining from the estrogen. And there's a couple different progesterones that we can use. I've starred estradiol and micronized progesterone because if you are looking for something called bioidentical, that's what you're looking for. But I want to let you know that bioidentical actually started off as a made up marketing term. And usually, though, what it has come to mean is a hormone that is chemically similar to what your ovary was producing. And then we can give these systemic hormone therapies either orally as pills or transdermal, meaning a patch that you wear, a spray, a lotion. There's even a vaginal ring. And there's pluses and minuses to all of these. So again, talking about bioidentical, the other piece I want to call your mind to, or talk about is compounding pharmacies. And in full disclosure, I sometimes use compounding pharmacies, but what we all need to be aware of are that compounding pharmacies are not regulated by the FDA. So there is some concern about possible overdosing or underdosing. Also, because they don't get regulated by the FDA, they don't have to put any of those black box warnings on their hormones. And that doesn't mean that their hormones are safer. It just means the FDA is not making them put those warnings on. They have the same risks as if you got your estradiol and micronized progesterone at CVS. And anything that comes from a compounding pharmacy is not going to be covered by insurance. And estradiol and micronized progesterone are FDA approved, and so therefore insurance will cover it. So you should definitely compare costs with that. So, a lot of people are really nervous to use hormones. And even if you're not sure where that initial fear kind of came from, you just know you heard that hormones cause breast cancer and heart disease. It all started with this Women's Health Initiative, or the WHI, back in 2002. And it is really quite remarkable how long lasting these effects of this study and the publicity have been. So, this study looked at women on hormones to see if it would help prevent heart disease, because we know that women's risk of heart disease starts to go up once she goes into menopause. So, they were looking to see, could we give hormones to these women? Would it protect their hearts? And what would the risk of breast cancer be? And what they found out is that women who were only on estrogen had no increased risk of breast cancer, and they followed them for 7 years. When women were on estrogen and progesterone, they had an increased risk of breast cancer after they were on those hormones for 3 to 5 years. The women had no increased risk of osteoporosis, diabetes, or colon cancer, but they did have an increased risk of heart attack, stroke, and blood clots. But a couple of things to keep in mind with that study was that the average age of the participant was 63. And so we often ask, would that risk be the same in someone who's younger? I mean, how could you really compare a 45-year-old perimenopausal woman to the risk that a 63-year-old woman might have? And then of course people ask, if they had used those bioidentical hormones, would there still be the same risk? So this can get pretty confusing. So what I like to do is follow the NAMS positions. The NAMS, they are the North American Menopause Society, started here at UH in Cleveland. And this is actually a pretty easy Google search for you. They put out this position statement in 2017, and a new one is coming out next fall of 2022. But these are some of the highlights. So, what they are recommending is that the benefits are likely to outweigh the risks for symptomatic women who start hormone therapy when they're younger than 60 or within 10 years of menopause. So, saying that hormones are a nice, safe option for younger women. There's no difference in effectiveness between that estradiol and that conjugated equine estrogen when we're talking about hot flashes, but estradiol is more effective for treating women who have those mood changes. So, personally, as a provider, that's the one that I always choose. And when you use adequate progesterone, there's no increased risk of uterine cancer. There is an increased risk of breast cancer when someone has been on estrogen and progesterone for 3 to 5 years, but that risk might look a little bit different than what you thought. So, that risk is less than one additional case of breast cancer per 1,000 users. That risk is similar to if you are obese or you don't exercise. That risk is actually less than if you're drinking the equivalent of 2 glasses of wine a day. So, yes, there is an increased risk of breast cancer after several years, but that risk might look a little different than what you thought. And there is an increased risk of heart disease, stroke, and blood clots. But again, that is women who are older, who start hormones after they've already been outside of menopause for 10 years, or if we're starting it with someone who's older than 60 years old. So again, hormone therapy, a nice option for younger women newer into menopause. hormone therapy at this time is not indicated to protect the heart or to prevent heart disease. So, for systemic hormone therapy, no longer do we have to tell women you always have to try non hormonal first. No longer do we have to tell women you can only take the smallest amount for the shortest amount of time. This can be really individualized between you and your provider to fit your needs and what is most beneficial for you, which is really how this should have been right from the start. Now, there are non hormonal treatment options if you either don't want to be on hormones or just is not the safest option for you. So, if you want to take a guess, how many FDA approved medications are there for hot flashes? It is a sad little one, but that might be changing. But right now, there's just one, but we have more options than one. So I started the one that's officially FDA approved. That one is Brisdal. That's a really low dose of paroxetine. Paroxetine at higher doses, usually starting at 20 milligrams, is used for anxiety and depression. At this lower dose, it works really nice for hot flashes and has a nice side effect for helping women sleep. Through my own experience, what I have found is that if I prescribe 10 milligrams instead of 7.5, it is so much less expensive and insurance is much more likely to cover it. That 7.5 milligrams of Brisdale, or the paroxetine, there's no side effects of weight gain or a decrease in sex drive, which is more likely to happen at those higher doses of paroxetine, so 20 milligrams or more. Other options, and even though they're not officially FDA approved, they have been studied, they're effective, they're safe, are these medications that are usually used for mood disorders, so anxiety and depression. So those are your SSRIs or your SNRIs. So those are really nice medications when someone's had a prior history of a mood disorder and they're having a reoccurrence. Because remember, I was saying those women who've had a history of depression more likely to have a reoccurring episode now in perimenopause. So if someone tells me, "Oh, I used to be on Lexapro, it worked really well. Now I'm having hot flashes and I'm definitely my depressive symptoms are coming back," then that's a really nice option for her. Um, However, if someone's already, say, on Lexapro for depression, but they're still having some bothersome hot flashes, you can't be on a second one, not even the Brisdale. So just one of these. And if a woman is on tamoxifen, so we use tamoxifen either to prevent a reoccurrence of breast cancer or to help prevent breast cancer in high risk women, that can have some drug. It can interact with some of these drugs in a dangerous way. So we just have to be careful with those ones. But there's other options too. So there's gabapentin. Gabapentin, we often use it for nerve pain. I use it with women that I work with that have something called vulvodynia, which is pain in the vaginal area. It has a nice side effect of drowsiness, so we can use that to your advantage, and you start taking that at bedtime. And after a couple of days, if you're still having hot flashes, you can go ahead and increase that dosing to up to 3 times a day. So it's nice because you can really tailor it for what you need. I have some women who only need it at night and other women who need to take it 3 times a day. There's clonidine, which is often used for high blood pressure. So the side effect is low blood pressure. This clonidine is not as effective as gabapentin or Brisdale, so I actually personally don't use this one. Or there's oxybutynin. So oxybutynin, we often use that for overactive bladder. Biggest side effect with this one is dry mouth. Has a really nice effect though on hot flashes. And if a woman is having symptoms over overactive bladder, so say she's getting up all the time during the night, um, you could try this oxybutynin. Helps with the bladder, helps with hot flashes. So a really nice option too. There's also non-hormonal and over-the-counter options, but I don't want any of you to assume that just because you need a prescription that it's safe, because the formulations, the dosages, they're not standardized. There's not a lot of studies done on these. So don't assume that these are always a better option than something that you need a prescription for. The North American Menopause Society also put out a big position statement on non hormonal options. It's several pages long. That is also a relatively easy Google search for any of you who want to read it in more detail. These are just some of the highlights. So, unfortunately, no research to support black cohosh, which I know is really popular, evening primrose, or flaxseed. A little bit of research might work would be vitamin E, pine bark, or pollen extract. Soy is a big one that gets lots of attention. We're looking for certain parts of that soy to bind to the estrogen receptors, and that's what helps with symptoms, but really difficult to interpret some of that research because only about 30% of women in North America have the right enzymes in their gut that to metabolize it to this S-equiol, which is what's important and helpful when we're talking about treatment for hot flashes. Some good news, cognitive behavioral therapy. That has lots of good evidence this works. So, what you need to do though is working with a skilled psychotherapist, a psychologist, and what they can help you do is work on these negative behaviors and negative thinking and improve your beliefs about coping and control. So, not so much decreasing how often you're having hot flashes or how intense they are, but just making it easier to have some control over them and to feel better and more positive about them. This is also a really nice therapy for help with sleep and mood changes too, and no side effects. So, this is also a nice option for you. So, lastly, I wanted to get into something that is very near and dear to my heart, something I feel very passionate about, and this is the genital urinary syndrome of menopause. And we can shorten it to GSM because otherwise it is a mouthful. We used to just call this vulvovaginal atrophy, but they changed it to this syndrome to be a lot more inclusive because this affects not only the genitals, but also the urinary system as well. So here you can see it kind of broken down and all the signs and symptoms that go along with this. So in the vulval vaginal area, you have a thinning and graying of the pubic hair, a reduced fat in the labia. The tissue can appear very dry and pale because estrogen really important for blood supply. The tissue is not as elastic. It doesn't stretch as well. You could be at risk for more reoccurring vaginitis. The pH starts to go up when it should be more acidic. You're more at risk for a prolapse. And the symptoms of this is vaginal dryness, irritation, burning, itching, discomfort. And this doesn't have to just be related to sexual play. This can just be day to day discomfort. I meet lots of women that tell me, I'm getting yeast infections all the time. What's happening? And it's this syndrome instead, it's GSM actually. In the urinary system, you can have more frequent bladder infections. You can start to leak urine. All of this leads to urinary frequency. So, going to the restroom all the time, a sense of urgency when you need to empty your bladder, and actually some discomfort when you're urinating. And then, of course, really negatively affects your sexual health. So the vagina actually gets more narrowed and shortened. You can start to have some bleeding with any type of penetrative intercourse. The clitoris, that glans that you see at the top, it can get really small and you can have scarring over the hood. And all of this leads to painful intercourse, a decrease in lubrication, arousal, sensation, longer time to reach orgasm, a little bit of muted orgasms, and of course, all of this affects a sex drive because I tell women every single day, of course, your sex drive is low with this. You're smart, your body's smart. Why would you want to do something that either you're not getting much out of or is uncomfortable? So, unfortunately, this GSM affects at a minimum 50% of all postmenopausal individuals. And unlike hot flashes, night sweats that should eventually go away, this will never go away and just gets worse with time. So, if you have not heard of this, that is because it is so poorly underrecognized, poorly treated, and only about 7% of women are being adequately treated for this. Hence why I feel so passionate about this. So, we have options for this. We can start with over the counter options. Those are for individuals who just have some very mild symptoms. So, you have lubricants, which are short acting, used during sexual play, moisturizers, more long acting. So probably you're already using moisturizers on your arms and legs. No reason to think you wouldn't need a vaginal moisturizer too. You can use water-based, silicone-based, or oil-based. They all have pluses and minuses to them. The big thing with the water-based ones is to avoid anything with glycerin and glycol that can cause some vaginal irritation. So check your ingredient list. Silicone-based are a little, the water-based ones can dry a little bit faster. Silicone and oil-based last a little bit longer. There is some concern if you're using any type of silicone sex toys that it could mess with that integrity of the toy. Oil-based, if you need to use condoms, it can potentially alter how strong that condom is. So those are things to keep in mind. And then, of course, we have prescription options. So, vaginal estrogen, one of my most favorite things in this world, right up there with milk duds. So, this vaginal estrogen, when your only bothersome symptom is GSM, all you need is this vaginal estrogen. You don't need the systemic estrogen. And it doesn't matter how old you are. We don't have to worry about this like we do with the systemic estrogen because it's a really small dose and a really small amount getting to the rest of your body. So you could start this at 85 years old and it would still be fine. So again, it's significantly lower doses, so much safer, no increased risk, heart disease, blood clots, cancer. You don't need progesterone. It does not alter the lining of the uterus. You can use this forever, which is actually usually what I recommend. They studied women for a year while they were on it, and their levels of estrogen were never above what they should be in menopausal women. Unfortunately, it has the same black box warning as the systemic hormone therapy, which has done a gigantic disservice to women because this scares providers, this scares pharmacists, and that warning is based actually off of that WHI study, not studies based off of vaginal estrogen. And they tried to get that removed from the FDA, but the FDA would not. So these are all of your options. So since you're going to get a copy of these slides, you can look at these at your leisure. You have lots of options. So don't let a price or anything persuade you. They all work equally well. I would love to say you pick whatever you want. I'll prescribe it, but usually I am limited by what insurance wants me to pick. But there are lots of options for you. There's two other prescription options for GSM. One is progesterone. That's an intravaginal DHEA. So DHEA works inside the cells of the vulva and the vagina to make both estrogen and testosterone. So again, just works locally. You have receptors for both of those in the genitals. So that is a really nice option. Aspamethine is a SERM, so acts like an estrogen in some tissue and anti-estrogen in others. It's actually the same drug classification as tamoxifen, is the only oral pill that you can take. Just so you know, though, from my own experience, if I try to prescribe this, usually insurance wants that woman to try at least one, if not two, of the vaginal options first. But this one is out there as well. And keep in mind with these prescriptions, this is your new lifelong vaginal care. You're never going to start ovulating again, get all your estrogen back. You're not supposed to. So, this needs to be thought of as what you're going to do from here on out. And the symptoms will come back. And it does take about a good 12 weeks for the full effect. So, don't stop after 2 weeks. There is also vaginal lasers, energy-based therapy. It's a relatively newer application for GSM. And what it does is we usually say it's like aerating your lawn, which I realize is not a super great visual, but it's making these little millimeters of damage in the walls of the vagina. And then when the body goes to heal, it brings in that blood flow and collagen and growth factor. And that's what helps make that tissue feel more like it did before you were perimenopausal or menopausal. Um, since this is a relatively newer application, there's not tons of research on the vaginal lasers, but the research that we do have is promising. This is a really nice option for women who don't want to be on that lifelong regimen prescription option. Usually we do this laser about once a month for 3 months, and then follow-up is roughly about a year. However, if this is not covered by insurance, you can use an HSA to cover it, to cover the cost, but that cost can be prohibitive for some people. So, in conclusion, when to call your provider? Frequent, heavy, prolonged vaginal bleeding. We just need to make sure that you're okay and that you're healthy, and it's just normal perimenopausal things. If you have any vaginal bleeding after you've gone 12 months in a row without a period, you need to contact your provider. Please, again, we just need to make sure you're okay. And please call a provider if you have any bothersome symptoms that interfere with your quality of life. We hope I've shown you we have lots of options out there. And my own personal final thoughts are, first of all, menopause is normal. We should all be so fortunate as to get to menopause and to remember to practice some self love and gratitude. Menopause doesn't have to be anything to worry about or be scared of. This can be a really nice time of new beginnings, new freedoms. You can reflect on all the wisdom that you've gained. So, thank you. I would be happy to take any questions.
Thank you, Jean. That was a great presentation. Thank you for sharing all of that information with us. So as a reminder to everyone, there is the Q&A button within the platform where you can enter questions, and we've had some that have already come in. So I'll start with those, but please feel free to put your questions in there, and you can put them in anonymously if you wish. We had one come in asking or saying that many of the symptoms of menopause seem to mimic thyroid symptoms, and how would you distinguish between the two?
That is an excellent point. Yes, they can mimic the two. So that is one time we would do labs. So especially if you have a family history of thyroid disease, and thyroid disease is more common in women than men, we could absolutely get a lab result, usually do like a TSH. And if it's normal, then we have a good answer that it's perimenopause, because you're right, it can mimic the two for sure. The estrogen and the thyroid hormones very closely linked. And there's also the possibility you could have both.
Thank you. And then another around what age do hot flashes normally start? This person said they're a young 82 and they're still getting them. Or normally stop, sorry, not start.
Oh, I am sorry to tell you, I don't know. They used to teach, actually, when I was first practicing, they used to teach us, oh, it's 5 to 7 years. And then now they've said, oh, the average is 10 years. And then, of course, now they're saying, oh, they call these people, I think they have the term super flashers or something. So for some women, and I meet lots of women well into their 80s and whatnot, and they have not gone away. Unfortunately, there's no lab I can do to tell you when that's going to happen and when it will go away. What I can tell you is that usually it should get better with time. The other thing I just want to remind those people out there that are still having some pretty bad hot flashes or hot flashes well, into 60s, 70s, 80s, is to make sure that someone's keeping an eye on your heart, because that could mean there is a link between women who have hot flashes for a long time or very severe hot flashes and an increased risk of heart disease. So they are linked. So I would be careful. And I wish I could tell you when they're going away, but I cannot, and I'm sorry about that.
And along the same lines, is it possible to only have hot flashes at night in bed?
Yes. So sometimes people distinguish between hot flashes and night sweats, but it's all the same thing. So I used to be a labor and delivery nurse, and so I always compare, if you talk to 10 women, they would describe labor contractions 10 different ways. I would say it's the same for hot flashes. So some women only have it at nights, when some women have it during the day. Some women, their feet get really hot and that bothers them. Other women are sweating in their hair. I mean, it's all over the place. It's all valid. You can feel hot flashes however you want. But yes, for sure, the hot flashes at night make it especially difficult to sleep well.
And then we had another one. We actually got a lot of great questions in here. Another around, is it common for women who are perimenopausal to experience hives on hands and or feet?
Definitely not common. No, I wouldn't say that. I have met other women that this happened to them. It's interesting. I haven't seen any research to say why that might be. So, hot flashes are linked again to serotonin, those neurotransmitters in your brain. Times of stress can bring on more hot flashes. So I'm curious if, sometimes people get highs when they're under a lot of stress. I wonder if that could be the correlation there between, breaking out with that, if that person is also under stress. But no, otherwise I don't have, to be honest with you, I don't have a really great pathophysiological reason for hives and hot flashes.
And then a question around, annual GYN exams and what are necessary for postmenopausal or hysterectomy patients. How often and what exams should they be getting?
Okay. So cervical pap tests for looking for cervical cancer for anyone who still has their cervix. If you've had really good screenings and no precancerous or high risk lesions on your cervix, you can start those pap tests around 65. Mammograms, though, every year. Um, Bone density tests usually starting around 65 years old, unless you have some other risk factors that maybe you need to do that sooner. As far and some of these things can absolutely be done in primary care. I would say that GYN care is beneficial for looking at the vulvar area, the vaginal area, the pelvis. So, looking for those GSM symptoms. When they've done studies asking about GSM and why it's so poorly underrecognized and undertreated, all providers do a bad job looking at this. It's a little bit better though for GYN providers for doing the exam. But if you have, someone should be doing a pelvic exam, looking at the vulva, the vagina, looking for skin color changes, whatnot. Any postmenopausal bleeding would be a good idea to see someone in GYN too. So I hope that answers your question.
Someone asked, and there's actually a couple of questions about bioidentical hormone therapy. One was how to figure out if they need bioidentical therapy or GSM therapy, having symptoms of both.
Oh, that's a great question. So, we could always start with the systemic hormone therapy and see if that's enough. There are some women who need to be on both, which is very safe and totally fine. So, if you're having hot flashes, mood changes, and GSM symptoms, we should start with systemic and try that for about a month. Usually, once you're started on systemic hormone therapy, you'll start to feel better within about 2 weeks. In 4 weeks, we're going to know, really how you're doing. And that's a good time to talk about, are those vaginal symptoms starting to get better? For some women, we need to add in a second prescription for the GSM symptoms. And again, really safe, totally normal. It's a great option.
And then is the bioidentical hormone therapy after menopause a lifelong commitment as well?
No, not necessarily. So again, once you're starting to get to that 3 to 5 year mark, you're starting to have that small increased risk of breast cancer. So that's a really nice time to talk with your provider about whether or not you want to keep going, risk benefits. Usually around that time, I have women see if they want to come off of their hormones, see how they feel without them. Some women feel fine. Some women, all their bothersome symptoms come back. There's no hard, fast rule. It used to be you had to stop at 65. That's no longer recommended. It's all risk benefits, what's working for you. For some women that I work with, they're like, I feel so much better. That small increased risk is worth it. I want to keep going. For other women, they're concerned about that increased risk. And so they come off of it. And sometimes they still feel great, or sometimes then we start talking about some non hormonal options.
Great, thank you. So a question, someone around 53 years of age with pretty regular periods, could they still be perimenopausal? They have some other bothersome symptoms of low estrogen and wondering if they could be a candidate for estrogen therapy.
Right, absolutely. Yeah, for some women, the menstrual pattern changes don't happen for a little while. Sometimes the hot flashes or mood changes are really what they start to notice first. So hormone therapy is so much safer in younger women. So absolutely, 53, perimenopausal, prime candidate for hormone therapy for sure. So that's a great option.
Great, thank you. A question around symptoms or issues. Is hair breakage a possible issue with menopause or symptom?
Yes. So absolutely, the estrogen receptors all throughout the hair, in the skin too. Hair gets dry, skin gets dry, eyes get dry. So absolutely. So with the hair, I wouldn't put someone necessarily on systemic hormone therapy just for their hair, but if you had some other bothersome symptoms, it's a really nice side effect of hormone therapy. Also, as we all get older, we just have to be a little bit more careful with our hair products and just making sure you're using gentle products, lots of conditioner, if possible, limiting, dyes and heat products and those kinds of things. But yeah, we all start to notice you have to start treating that hair a little bit more delicately than probably what you could get away with before.
Great, thank you. And then a question around the lubricants. I'm not sure specifically which one they're referring to, but they said, can the lubricants cause bleeding?
The lubricants, if you're using, so the water-based ones, there's the potential for some vaginal irritation. So if they have, depending on what they're adding to their lubricant. So in a perfect world, your lubricant, your water-based one should have a pH that matches your vagina. So 3.5 to 4.5. It should be isoosmotic. Really difficult to find that information on products. So that's why we're avoiding glycerin and glycol, which are the two main ingredients that cause problems, avoiding products with those things. But that being said, if you were using a product that had some harsh ingredients in it and that vaginal tissue was already kind of thin and susceptible, absolutely you could have some bleeding, during some type of penetrative intercourse, just because that tissue is not super healthy. And then perhaps you're using a product that is too harsh. So absolutely that could. The lubricants and moisturizers wouldn't cause bleeding from the uterus, though. It wouldn't cause any problems in the lining, if that's what the question was.
Thank you. I think you touched on this a little bit already, but a question, is there a correlation between menopause and developing various heart arrhythmias?
No, not so much an arrhythmia, but when you have hot flashes, some women do have palpitations or their heart rate goes up. So it could feel like an arrhythmia just when you have a hot flash. But as far as developing a permanent arrhythmia because of menopause, no, but it could feel like some heart palpitations during hot flashes.
Okay, thank you. Can asymptomatic UTIs be related to menopause?
Absolutely. Absolutely. That's part of the GSM. So when a woman loses all that estrogen, a couple of things happen. So one, the pH starts to become higher, more alkaline, which can cause more bacteria to grow. Also, the vagina gets more narrowed and shortened. So the urethra, where the urine comes out, becomes a lot more prominent. So those two combinations can cause, an increase in bladder infections for sure. So going on an estrogen prescription, or the other two prescription options, are a wonderful preventative method for preventing bladder infections.
Thank you. A question around symptoms, again, for menopause. having someone having periods every couple of months or sometimes every month in a row for around a year. They're in their early 50s and they have some weight gain and insomnia. Would that likely be menopause or perimenopause?
Absolutely. Perimenopausal. So classic. Yeah. So not ovulating on a regular basis, fluctuating hormones. So at times they're really high, other times really dropping off pretty significantly. So um, the not ovulating on a regular basis and those fluctuating hormones is the reason for the irregular period. So skipping a couple months, and then maybe they get regular for a while because you start ovulating again, and then you stop ovulating on a regular basis, so they become more irregular. And then it's those fluctuating hormones, the overall decrease in estrogen causing the hot flashes, night sweats related to weight gain, joint pain, all of that for sure.
Great, thank you. And then I have a two-part here.
Okay.
And they're related. Is it normal to, and you covered a little bit of this, but to start getting a lot of acne and hair loss during menopause? And then will hormone treatments help with those issues? And then the second part is, can someone, if you go on those hormone replacement therapy, they've heard that it increases the chance of cancer. So two-part one there.
Okay. So the first part, absolutely, the hair changes in acne related to perimenopause, menopause. So the hair loss on your head is related to that decrease of estrogen. The acne, and perhaps if you've noticed any hair growth, say on your chin or your chest, that's related to that increase in available testosterone for your body to use. So a lot of times testosterone is bound up with estrogen. So as you lose your estrogen, you've got a little bit more available testosterone to use. So acne, hair growth, but unfortunately thinning hair on your head. So for sure, perimenopause, menopause, 100%. Um, and then hormone therapy can help with those things too. So what I would recommend for someone with those types of symptoms would be an oral estrogen. So oral estrogen would help with the hair on your head and would bind up some of that testosterone to help with acne and if there was that other hair like on the chin or the chest. So that would be great for that. Again, FDA approves the use of hormone therapy for hot flashes to prevent osteoporosis for the GSM, but we could absolutely talk about risk benefits with acne and hair changes and those kinds of things. Did I answer both parts of that, Samantha?
I think so. Sorry, I should have given them to you separately. The
Okay.
second part was just around, I think, the risk factors for hormone replacement therapy.
For cancer. Yeah. So the risk of breast cancer is a small increased risk, less than 1 in 1,000, after being on hormones with progesterone for 3 to 5 years. Um, Again, that may or may not be a little conservative because those are studies based off of different hormones on older women, but it's still there. No increased risk of cancer in the uterus when you use progesterone, and really no other risk for cancers. Breast cancer is the big one that everyone worries about, and it's there, but it's still relatively low.
Thank you. So a question around some side effects with patches, specifically estradiol patch and cramping. Is that a common side effect? Also with taking progesterone with that.
The progesterone is usually the one that causes the cramping. So progesterone, we use it again to protect that lining of the uterus. So that's going to keep that lining really small. Sometimes we give progesterone to help women to help shed their lining if it's too big. So that can cause some of the cramping. With the estradiol, the biggest complaint that I usually hear about is some breast tenderness, which doesn't mean that something bad is happening. It's just a reaction to hormones. Um, and then sometimes there is some bloating with hormones, which is usually progesterone, but it could be estrogen too. Um, and so what we could do if that were the case is to decrease the dose and see if that helps. And then some women I've worked with, if they had that initially with time, it did get better as your body got used to it.
Thank you. So we have time for one more question. This one was around, I guess, who to see for menopause. Is there any times when you would see a specialist regarding issues related to menopause that a GYN wouldn't be able to treat? Or who is the best person to go to for menopause symptoms?
So there's a lot of people that can treat menopause. I think an relatively easy way to find them is if you went to that North American Menopause Society. They'll have a list of providers. You can take a certification course and class, and you have to keep up to date with all the latest research and whatnot to stay certified. But that's a really nice way to find individuals that are specializing in menopause. We are super fortunate here in Cleveland to have so many medical resources at our fingertips. So you can absolutely find people that love menopause and specialize in it. That being said, that could be primary care, that could be GYN. I would just say if you are seeing a provider and they're telling you things that perhaps don't sound right or not quite what you were hoping to hear, you can always, try to get a second opinion from someone else. And like I said, someone who's staying up to date with all the latest menopause research. It does change pretty quickly.
Thank you. So we're almost at time here. I wanted to thank you, Jean, for your time and sharing all this wonderful information. And thank you, everyone, for submitting your questions. As we mentioned, we will email a link to view this session on our website once the recording is posted, so you can come back and see, especially those great slides that had, all the information in there. And then if you are interested or in scheduling an appointment or either in person or virtually, we have the number up here, 440-623-7745, and you can also find Jean on the UH website as well. And so that concludes today's session. Thank you for attending and have a wonderful evening.
Okay, thanks everybody.